This is Michael Barraza recording in Baton Rouge, Louisiana. I'm honored to welcome Dr. Aron Chary. So, Aron, why cryo? You know, we've got different ways to treat pain. We've got different ablation technologies. We've got chemical ablation. Why cryo?
Yeah, good question, Mike. It's, cryo was something I, again, was really introduced to, especially with regard to pain when I was at Emory and kind of working with Dr. Prologo. You know, we had cryoed other things, renal masses, other soft tissue tumors. So I was familiar with the technology, but I really didn't understand or know the concept with regard why for pain. And of course, you know, there's been a lot of talk on prior podcasts about sort of the pathophysiology of cryo with regard to nerves. You know, you get this whole Sunderland 2 type injury, and really the premise is not just to turn off pain signals, but to induce this whole Wallerian degeneration and neuroregeneration, which was a concept I was not familiar with.
Same.
And so the thought is, you know, not only are we helping the pain on the front end, but there's that potential to create a brand new nerve that essentially didn't have that injury prior to. And so does that create, you know, longer duration of relief? Is that really going to give just a more durable outcome? And I think that's what's really being studied, especially when comparing to other, you know, neurolysis modalities, you know, ethanol, other chemicals, RF ablation, things like that. We've tried to sort of figure out how you can do some studies with the knee, for instance, comparing, say, RF to cryo, and that's not really been done to my knowledge as of yet. But, you know, the thought with the knee, for instance, again, is that you're potentially creating a longer duration of relief. Now, we don't necessarily have that validated yet, but I think that's the thought. And so cryo, you know, for other reasons, it's, you know, being able to see and visualize the ice ball. I think for certain areas, it can be a little more gentle on adjacent structures, more controlled as well. I think you can titrate your ice. You can kind of see if it's getting to an area that is not safe, then you've got the ability to halt that and control that. So there are a lot of advantages and that I think are important. And then even coverage, you know, ablation zone coverage, I think is especially with regard to nerves and single probe usage. So those are some of the things that I think are interesting and important about cryo that I learned that could potentially be advantageous.
Aron, in what circumstances for cryoneurolysis do you do a block first? And if you do it the same day, or do you do it and then bring them back for the neurolysis?
Yeah, good question. And I know it's probably been talked about before on some other podcasts, but, you know, we'll just say, for instance, for non-cancer related pain, almost always I'm doing a block prior to. If it is for, say, the genicular nerve, you know, again, kind of going to our algorithm of sort of how we treat knee pain, a lot of patients we're triaging with the block. And, you know, unless they come to us with, you know, recurrent hemarthrosis or things like that, we're kind of going to the block first to see if that works. And if it does, then we're going to the ablation. You know, same with the pudendal and, you know, intercostal and things like that. It's kind of a dress rehearsal for me and for the patient to sort of understand, you know, not only are we trying to test if this is diagnostic, if this is truly your pain generator, but it's going to kind of give you a sense too of what we're doing. And, you know, if we're going to commit to the cryo, it gives me a little time. You know, these are usually not urgent cases, so it gives me a little time to coach them and get expectations in order. And also just to make sure that, you know, before doing a cryo, it's going to work. So I really do block most of the non-cancer pain syndromes if I can.
Yeah, I'm with you. You talk about setting expectations. Let's take, you know, the pudendal, for example. What do you tell them in terms of what to expect after, you know, including when you expect them to have pain relief and how long you expect it to last?
It's a good question. And again, I think that, you know, depending on the etiology of the syndrome and kind of how long it's been going on for, what the inciting injury would have been, I basically tell them, I think this is what you have. And sometimes if it's not clear, then, I make that, I'm upfront and I say, your symptoms seem to point to pudendal neuralgia. You've got some other ones that don't quite add up, but, let's try this block first. And if it is in fact pudendal neuralgia and we do this block, and I generally do these with CT guidance because I know exactly what I'm targeting and if I'm hitting that target. And I tell them, if basically you get relief from this block, and it won't be subtle, it's going to be, you're going to know, and you're going to be able to tell me that this was a positive response. And if that's the case, then this is the target, this is the pain generator, and you do have pudendal neuralgia. And when we do the cryo, I generally try to counsel them on what I think, and this is after a positive block. I say the cryo is going to help you. Here's what I think could happen afterward, for cryoneurolysis in particular. And I think, again, this is kind of alluding back to some of the teachings from Prologo. He talks about sort of his 3 buckets of responders. And I've had a similar experience, in my practice where you get this first set of responders where they almost get immediate relief, or it's almost like the day after. I did an intercostal cryo recently, and within 24 hours had complete pain relief. And so that maybe is that first, bucket of responders. And then you get kind of this second area where they respond, but it may take, 2 or 3 days, may have, some inflammation, a little bit worse pain, what have you. But in general, it's very mild and short-lived, and they'll get some good pain relief. And, sometimes that could be from a tumor deposit or, encroaching on a nerve, and you kind of release it. And there's that third bucket, which I've had a couple experiences recently where you cryo a nerve, and for weeks and sometimes up to a month, they actually have worse pain. And I had a lady that I treated for pudendal neuralgia that was one of these, a benign etiology, very athletic. She had done a lot of horseback riding and various things like that. And so we did the block, and, literally like 6 hours after the block, completely pain-free. It was like a miracle for her, and she had been hurting for years. But, her story was a little bit ambiguous and wasn't sort of this clear cut. She had some lower back pain, she had some other pain that didn't quite fit the bill, but she had enough of the criteria that we thought pudendal was a good option. So after the block, we did the cryo, and I told her, I this is what we might expect. The pain may not be instant. I kind of gave her that whole responder speech, and you could be in one of these areas. Long story short, for about 3 weeks, really about 3 or 4 weeks after the cryo, she had, just almost worse than pudendal neuralgia. I mean, she had this exquisite sensitivity, this vulvodynia. It almost felt like she had like a sunburn around her whole perineal region. And what I learned there and from, various other cases is that you really have to see them in clinic and reassure them. And, I said, look, these, you're kind of in this third bucket here of what I think. And I, my hope and what I know is going to happen is that, this nerve's going to go through a process where there's a lot of inflammation, there's a lot of infiltration, and you've got this worse pain, but it's going to get better. And, after a month or so, a lot of that inflammation is going to subside, and, you get into this sort of Wallerian degeneration part, and then this nerve is going to grow back. And you're, the hope is after some period of time, and it could be weeks to months, you're going to feel better. But now it's a little bit of a long game. And, that's hard for people who were previously athletic and very active. And, all of a sudden, they're like, what have we done here?
Yeah. My first one I ever did was a very similar story and a very similar result. And I'm the one that needed the reassurance. Like, I called Prologo in a near panic. I'm like, what happened? He's like, it's fine. Just cool off.
Yeah. And I think that's another testament to cryoablation. Really, it's got that profile of creating, a nerve injury that's reversible, and that's the intention. And so, there's some reassurance there. And again, I think it's just counseling the patient, making sure they understand, I'm going to get you through this, and it's going to take some time, and that can be a challenge. I had one younger lady I did a stellate cryoneurolysis on, and again, we did the block. She had left-sided complex regional pain syndrome, and we don't do a high volume of these, so every time I do them, it just, kind of like, all right, we're going to do this. But she did great on the block, and then brought her back and did the cryo, and a lot of the symptoms she was having with the complex regional pain went away and did great. But I think what happened is my ice ball potentially clipped kind of an inferior C7 cervical nerve root. Mm-hmm. And so she got these motor deficits in her left arm that, she barely lift her arm. And that was terrifying. I was like, oh gosh, what's happened here? And so it took a good 6 months to get her through that, to where she's doing great now. In fact, she's super happy, because now, the arm is essentially repaired, and all the symptoms she was having from the complex regional pain are essentially gone. But, you get these cases where these things happen, and you've got to really work through it and reassure them and let them know, these motor components will come back. And so I found that to be, a learning process and a challenge that we do a lot of other types of procedures, uterine fibroids and various things where or even with kyphoplasty, things like that, where you just, when you're done, and you don't necessarily have to, continue kind of coaching your patient through the process and reassuring them. So there's that sort of, labor intensive component sometimes of pain and pain intervention.
Absolutely. And I don't think this is something that I would have been able to handle before I had a clinic.
Yeah. It's been said, a million times over, but, the clinic it's really more, I used to think, well, you should have a clinic. That's what everyone says. And you got to see your patient. But, more and more I understand why. And it's, I have the ability to schedule a patient weekly for follow-up if they're able to come and see me. And like having that freedom to do that, really, it's good for me. It's good for the patient. And I don't see patients every week like that. But if I have a patient that had sort of an adverse event like that I need to just make sure we get them through it, then, having a clinic is so pertinent to be able to do that.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTableMSK on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Junroy Kennebrew.
Thanks again, and see you next time.